It's really good to be with everybody. Welcome. So I understand we have people from India area as well. So good morning to you guys and good evening to everybody here in this part of the world. My name is Harrell. I am super excited to be with you for this hour. Just an aligner introduction webinar to pique your interest. Hopefully you'll learn something and enjoy talking together for an hour, but more than anything to just pique your interest in the awesome courses that we have coming up in aligners. I imagine that we have a mixed group of doctors. Probably some of you have done braces and maybe have done a little bit of aligners and realize that you need some more training in aligners to better understand that appliance. There may be some of you who have never done braces, but have done a limited amount of aligners in your practice and realize that more training would be valuable to you. And there may be some of you with us who have never done any orthodontic services in your practice and that you are considering offering orthodontic services to your patients as a general practitioner, or we have pediatric dentists who join us. We sometimes have prosthodontists or periodontists who join us and incorporate orthodontics into their practices as well. I love talking about orthodontics. I'm super excited to be with you guys. The Progressive Orthodontic staff will keep an eye over here on the little chat messages. So if you have questions specifically for them, you can put them in there. If you have a question for me, we'll take questions at the end. We'll stick around for a few minutes and answer questions. So to introduce myself, this is my family. I've been married for 27 years. My wife just celebrated a birthday yesterday. It was awesome. I have 4 boys, you can see in the picture here, who are growing into grown men. 2 of them have gotten married in the last 2 years. So I have 2 daughter-in-laws, and we've always wanted girls, and we're super excited to have these awesome girls in our lives. I ran a general practice in San Clemente, California for almost 20 years and had a outstanding, fabulous, probably best in the world team. Love my team. They're like family. I started doing orthodontics in 2000. Well, I started training in 2007 with Progressive Orthodontic seminars. I looked into their seminars when there was a downturn in the economy and the cosmetic work was starting to slow down. And I sensed that we needed to stop referring out so much work and keep more things in-house. So I considered, more training in oral surgery, more training in periodontal surgery, more training in endodontics, or more training in orthodontics. And I looked at how many cases I was referring out in each of those different specialties and found that I was referring more orthodontics than any of the other specialties. And I wanted a better understanding of orthodontics anyway, because parents always ask me like, hey, does my kid need braces? And I didn't really know how to answer because if it wasn't obvious, I didn't really know what I was looking at. So I found Progressive Orthodontic seminars from an uncle, a dentist of mine on my wife's side, who I knew did a lot of braces in his general practice. And so I was curious as to who he used, and he turned me on to Progressive Orthodontic seminars. And I had dabbled a little bit with Invisalign, but knew that I was just getting myself in trouble. So I hadn't done much, but I knew that they offered a comprehensive orthodontic course. So I actually started with their traditional series and learned how to do braces first, and then took what I learned from the braces and applied it to aligners. They didn't teach aligners at the time, but now we have an awesome aligner course. Love doing orthodontics. It's probably one of the best things that I ever did in my practice, besides choosing to be a general dentist, was putting orthodontics into my practice. And I'll show you why in just a minute. But you hear me talking in past tense because a couple of years ago, I started having some motor problems with my hands. Some fine motor skills were not working well. And I found out that I had some pretty severe cervical spinal stenosis and had to have surgery and get the pressure off of my spinal cord, but there's permanent damage done. From the position that we sit in doing dentistry and my genetics, I guess. And so I had to sell my practice. And fortunately, even though I don't practice clinically anymore, I had done, aligners and braces in my practice for about 10 years and had wonderful experience, and had the opportunity then to join Progressive Orthodontic Seminars team of instructors, and have been able to travel the world and teach live courses and Zoom courses as we're doing right now. And I just really enjoy teaching, and I enjoy mentoring and doing consulting on an individual basis with doctors on their aligner cases and their braces cases. So here's a quick slide just kind of summarizing for me why I love offering orthodontics in my GP practice, and why, if you don't already, I would encourage you, and those of you who may be doing a little bit, to encourage you to consider really upping the amount of ortho you do and referring out fewer and fewer cases. One, I just love ortho. It's the fun that you get out of doing a really awesome cosmetic case for somebody, where you give them the confidence to smile, they feel better about themselves, you see them start, they get a better job, they get a new hairstyle, they lose weight, they start, just their life changes. And it's all started from you offering them, providing them with a better smile. And all of my cosmetic work was always on adults. I never really got a chance to do much cosmetic work on younger kids. But all of a sudden, when you do ortho in your practice, you have the joy of basically doing cosmetic services on kids, sometimes young kids, 7, 8-year-olds who have their teeth sticking out crazy and they're embarrassed to smile and they don't feel good about themselves. And you start changing that. And when they come in, you can just see that they carry themselves differently. And it just brings a fun energy into my practice. And I love that about orthodontics. It makes your career exciting. It also definitely made me a better practitioner. I feel like you only know what you know. You only see what you have been trained to see. And we don't get a lot of orthodontic training in our dental schools when we graduate from dental school. And so if we don't take additional orthodontic training, we really don't get to see through the lens that an orthodontic practitioner sees and understand the way that the mouth moves, the way the teeth move, just understand how dynamic the mouth is. Before I did ortho, I just didn't want the teeth to move. I put a crown in, do a filling. I just don't want anything to move because I don't want contacts to open and, things to change. And when you do ortho, you want things to move. So all of a sudden you see the mouth as this more dynamic thing that's influenced by the tongue and the lips and the function. And you understand why teeth are moving and why they're not moving. And so you just have a much better lens through which to view the whole patient. And so I think that you become a better practitioner. It really helps with recessions. We're going into a period right now where the future is a little bit uncertain. And if you can keep more cases in-house and not have to refer out, that's one thing I love about ortho, is it really patients pay over time. And so there's this constant flow of income and you increase your bottom line because you do ortho in your practice. Plus, it brings a lot more aesthetic work. When you start asking your patients, hey, have you ever thought about straightening your teeth? It always leads into a conversation about, yeah, I have, and I've never liked this tooth. And you end up not just doing orthodontic work, but you end up doing a lot more cosmetic work, whether it's replacing old crowns or, completely doing a bunch of veneers or whatever, full mouth rehab. You end up doing a lot more comprehensive treatment and aesthetic treatment when you're having these conversations with all your patients about straightening their teeth. I also found that when the specialists in town, the oral surgeons, the endodontists, the periodontists, when they would see the work that was coming out of my practice and realizing that my patients were getting all of this done in one place, they would refer more complicated cases to me as the general dentist because they had confidence in my abilities to understand the case, the complexity of the case, and do the ortho if needed in addition to whatever else was needed. So it really increased my referrals. It's way easier to treat perio. Perio is much easier to treat when teeth are straight. So anytime that I'm trying to improve the periodontal condition of my patients, I'm always considering orthodontics because it always plays a role in improving the perio in a patient. It helps with TMJ problems. It helps prepare for implants. There's a lot of times where it would be inappropriate to place an implant until the teeth around it are spaced and positioned properly. And obviously leads to many different opportunities for prosthetics, larger cases. So I just love ortho. Oh, one thing I didn't say is on this referrals, not only is it referrals from specialists, but you'll be getting referrals from kids. This one I loved. I loved when all of a sudden you get a whole new family that come into your practice and you're like, how did you find out about us? And they go, oh, our daughter who's 12 is friends with this little girl who's 12 that you're doing braces on. And so now all of a sudden, my teenagers and my young kids are sources for referrals because they're walking around with braces on or getting treatment done and they're telling their friends about it. And you're getting whole new families from that. So that is cool. So a question for you to consider: how many ortho cases are you referring out each month? How many cases are not being recognized? How many people come into your practice that would benefit from ortho and they're not being referred to an orthodontist or treated by you? They just aren't being diagnosed as an orthodontic case or treated. How much production is being unrealized because you're not diagnosing ortho? The majority of orthodontic cases are not detected due to a lack of knowledge by the GPs. Okay, so there's huge amounts of opportunities in your practices to provide amazing care. It's not just aesthetic. It's not just like, oh, well, your teeth will look better. They do look better, but there's so many benefits to the patients periodontally, functionally, in preparing for other restorations. Just it is an awesome thing to be able to offer to your patients. So some of you may be doing braces already. I do provide in my practice both braces and aligners. Today, we're going to talk more about aligners. And there are some advantages and disadvantages to aligners. And it's one of the things that I discuss with my patients when I'm offering them, options, choices regarding one versus the other. Incidentally, the courses that we teach are called Aligner Plus. And that's because one of the things that we teach you is not how to do comprehensive cases with braces, but in our aligner courses, we have hands-on experiences, and we teach you how to put braces onto a case. We want you to be confident and comfortable putting braces on, because there's a lot of cases that would be really difficult to do with an aligner, but 3 to 6 months with braces on one or both of the arches can take some of those really difficult things to fix, like a rotated tooth or a tipped root, just something that would be difficult for an aligner to unravel and fix, but you could throw braces in for 3 to 6 months and straighten some things out to the point where aligners would be able to take it the rest of the way. So some of our adult patients or even teenagers who are like, I don't really want braces, they're thinking, I don't want braces for 2 years. But if you can show them that they can do aligners, if they'll first wear braces for 3, 4, 5 months, they're happy to do that, knowing that they're going to get the braces off and finish up in aligners. So we do teach you braces. We do want you to feel confident putting braces on. Sometimes we need to start cases with braces. Sometimes we need to finish them. Maybe the patient's not wearing the aligners well. Maybe the teeth didn't move the way we wanted them to with the aligners. And sometimes we have to kind of finish up a certain thing with braces. So it opens up the number of cases and the complexity of cases that you can treat if you learn how to do a limited amount of braces in your practice. So some advantages of aligners, okay, over braces. They can be removed, okay? This is very nice for taking them out to eat, taking them out to clean the teeth, taking them out for special events like, I'm speaking in front of a group, or it's a wedding, or I'm going out on a great day, whatever it is, you can take them out for those opportunities. But one of the major disadvantages of aligners is the same thing, the fact that they can be removed. Now that can create compliance issues, right? So patients with braces, they don't remove their braces unless they go out in the garage and get a pair of pliers and pull them off their teeth. So the braces are always on and always working. Whereas with the aligners, we rely on the patient wearing them 22 hours a day, and they don't work if the patient's not wearing them. So compliance is crucial. And the patients can lose their aligners. They take them out, they put them in a napkin, throw it away. They didn't realize it. Now they don't have their braces on. They don't have anything to align their teeth with until you can get them a new aligner, or the dog chews them up. Okay, so its greatest advantage is also its greatest disadvantage. Other advantages, aligners are almost invisible. For patients who think they're completely invisible, we have to help them understand that they do have some bumps on their teeth. We have these little engagers and attachments where we need them. And you can see them, people do see that they're on their teeth. It's not completely invisible, but they look a lot less visible than braces. Some people experience weight loss when they are wearing aligners because they have to take them out to eat. And so they find that they eat less often. They eat more at meal times. Also, some patients who have like tension headaches and they're clenching, a lot of those headaches and the pressure in their head and the pain in their teeth will go away when they wear their aligners. It might come back after aligner treatment, but while they're wearing aligners, they feel much better because the aligners discourage the clenching and grinding of their teeth. It's easier to visualize the treatment before you start with aligners because we have these ClinChecks or 3D setups. Every different aligner company has its software that it uses so that we can visualize the treatment plan in 3D and each different stage of treatment before we do it. And some types of cases treat better with aligners. For example, if we need to kind of take an arch, we'll show you a little case in a minute here where we take an arch that's kind of constricted and we develop a better arch form. We do some expanding of the arch. Not the kind of expanding where somebody has a bad crossbite and they need one of those rapid palatal expanders with a crank on it. It's not that kind of expansion, but it's just a slow, gentle development of the dental alveolar process that works better with braces than, or better with aligners than with braces, because the aligners are pushing on the teeth from the inside. And patients that have dental open bite, so their teeth don't come together in the front, I'll also show you a case like this in a minute. The aligners are actually a better appliance compared to braces for closing dental open bites. Aligners tend to deepen the bites when the patients wear them. And that's due mainly to the fact that there's aligner thickness in the back of the mouth compared to the front. So as the patients function and squeeze their teeth together with the aligners in, it tends to intrude the back teeth, which deepens the bite in the front. Braces tend to open bites. So braces are better for deep bite cases, and aligners are better for open bite cases. Okay, so for me, there are some cases where I encourage the patient to go towards one or the other just because that particular case is going to treat better with one or the other. Okay, so the disadvantages I see is sometimes it can be more expensive for the aligners. Sometimes they can be difficult to remove, like they can be super retentive. And if a patient has arthritis or they don't have as good of dexterity, it can be difficult for them to get their aligners out, or they have really nice fingernails. There are tools that are sold to help people get their aligners out of their mouth, but they can be difficult for some patients to get in and get out. And like I said, there are some things that just don't treat as well with aligners, like deep bite cases, patients with really strong musculature. If there's a lot of rotated teeth or a lot of tipped roots or roots that need to move, as in like an extraction space, and we're trying to move the teeth through bone, we don't have as much control of the roots with aligners as we do with braces. So like if there's front teeth where we need to control the torque or the twist or the angulation of the front teeth, we do much better controlling roots with braces on teeth, whereas aligners, they pretty much just do a good job of controlling the crowns. They can tip the crowns, we can do some rotation, we can move roots to some degree, but we have more control with braces. So sometimes we get incomplete corrections if we use aligners. Okay, and that's part of what we teach you in these courses is how to recognize a good aligner case, what things are going to be difficult, what things are going to treat easily. When you take the courses and you use us as mentors, consultants, we do kind of free checks. So I have doctors who email me cases or send me through our software, which is called SmileStream. They send me records of a patient and just go, hey, do you think this is a good case for me based on my experience? And I can look at it and just look at the conditions and say, maybe not. Let's wait until you've had a little bit more experience, or yeah, this would be a great case for you. So case selection is really important. Just to touch on a couple of the common aligner problems, some things to think about, like why would I need to take aligner training? Why can't I just take an impression, send it off to Invisalign or ClearCorrect or one of the other? In fact, we do work with all of the aligner companies. So even if you make aligners in your own practice, we can do consulting and mentoring for any aligner company. And the things that we teach in our courses are not just about one company or another company. We're teaching how to use aligners, okay? What are the orthodontic principles applied to straightening teeth with plastic, with aligners, as opposed to braces. And then those ideas can be applied to any different aligner company or appliance. So why would you need to learn this? Why can't you just take records, take an impression or a scan and send it to Invisalign or ClearCorrect or some other company, let their technicians straighten the teeth for you, and then they send you the aligners and you give them to your patients? You're kind of a pass-through. Almost like a third party in the middle, or the middleman between, the aligner company and the patient. And if that were the case, we might as well just let companies like Smile Club Direct, where they just get the dentist or the orthodontist out of the way and just deal directly with the client. Those cases sometimes go okay because the patient had a condition where simple aligner treatment, like just hand them the aligners, it's going to work. But that's not always the case. And often it's not the case. There's a lot more to consider. There's teeth that aren't going to move the way they want them to. They can get the teeth straight within each individual arch, but there's coordination problems between the arches. Okay, so some of the problems that we face with aligners that we need to have training for is, some of them are listed here. One is we don't take full orthodontic records and consider the facial balance. I'll show you some pictures in a minute, okay? But it's not just the way the teeth look. It's the way the teeth look in the patient's face. It's evaluating the whole face and the aesthetics of the whole face, and not just the retracted picture where we just see the teeth. Okay, because one way to straighten teeth on one patient might look good on them, and on another patient, it might be the wrong way to straighten it. And I'll show you pictures in a minute. So for example, does the patient have lip protrusion? Do their lips stick out too far? Or convexity to their face? Or do they have a concave profile? Are their lips too far back and their lips need to be moved forward? Because how we're going to treat this case is going to depend on more than just what the teeth look like. It's going to depend on what their face looks like and where the teeth are located within their face, basically. Okay, proper case selection, knowing which cases we can successfully treat based on our level of experience and which ones we're going to get into trouble. I was one of those people that hated, getting halfway through an extraction and having to refer it to an oral surgeon because I was in over my head, or getting halfway through a root canal and having to refer it because I'm in over my head. If I'm going to do something, I want to feel like I have the training and I'm educated and experienced to the level of a specialist. And if I'm going to start that case, I can finish it. Okay. And so understanding what cases are we're going to get ourselves in trouble, what are the red flags, so that we choose cases that are appropriate for our level of experience. We want you to treat every level. We don't want to just limit you to just really easy cases. We want you to treat complex cases. But to get there, it's going to be a process of learning and gaining experience so that you can build up to a higher level where you're taking more complex cases, or maybe taking the full, traditional series of courses through progressive orthodontics. So you know how to do complex braces and aligners, and you can bail yourself out. Failure to set up a design or design a setup that addresses and compensates for difficult and less predictable movements. What I'm saying there is, when we get back a ClinCheck or we get back a 3D digital setup from the aligner company, we're the doctors. We're the ones who are in charge of dictating to them how we want to treat the case. Okay, we don't rely on the technician to know. They're not orthodontists, they're not dentists, they are technicians. They're supposed to be there to use the software to follow our instructions, to treat the case the way we've asked them to treat it. Okay, so we're the ones who have to look at it and say, what are the difficult movements here? How am I going to compensate for that? Which ones are predictable, which aren't? How am I going to treat this? Rather than just relying on technicians to straighten the teeth for us and we just hope it works. We deliver the aligners and hope that whatever the technician did is going to work out. Then as the patient goes through treatment, failure to recognize and resolve tracking issues, okay? Pretty much every case except for the most simple cases are going to have issues where the teeth aren't following the aligner the way we had hoped. They're not tracking, okay? So knowing what we're looking for when they come in to be able to tell whether the teeth are moving with the aligners or not. And then if we see something not tracking, knowing how we can resolve that without having to just get new aligners. There's tricks for getting the case back on track so that we can continue with the aligners that we have. And those are some of the things that we spend quite a bit of time going over so that you feel confident with your cases. And then not understanding and setting proper expectations with the patient from the beginning about what it is to wear aligners, what the commitment level is, is there going to be discomfort? And then also helping them understand that sometimes there's a need for auxiliaries. Okay, I'm going to show you a picture of that in a minute. They might need a little bit of braces. They might need a little button on their teeth with some elastics to move things around to help the aligners. There's different types of auxiliaries, things that we can add to the aligner treatment to get the teeth to move the way we want them to. And so patients understanding when those might be applied so that they don't see our aligners as not working. It was something they expected from the get-go. So here's what I'm talking about with looking at the whole patient. Okay, orthodontists are supposed to quantify the facio-dental complex, not just the teeth, but the whole face. Okay, so we take full orthodontic records on our patients, including all of the pictures of their face. We teach you what a full set of records look like, plus panoramic x-rays, lateral cephs. We talk about all this stuff. Okay, but this stuff is really important to treat at the level of a specialty. And the first thing we look at on patients is, what is their facial balance? Okay, this patient, it's the same patient, we've just altered the image here, but a patient that looks like this, it has a convex profile. A patient looks like this has more of a straight profile, and a patient looks like this has more of a concave profile. Okay, and so in each one of these cases, This patient might want to reduce the protrusion. Those lips might be sticking out too far. This patient might have really nice balance and be happy with it and just want to maintain that. This patient might want to have her lips a little bit more forward or more, filled out if possible. Definitely wouldn't want to pull those lips back. Okay, so if we look in the mouth and we find out that there's spaces between this patient's teeth, that's really good on this patient because that means that we can just close the spaces by pulling the front teeth back and her profile is going to be improved. But on these two patients, if there's spaces in there and we close those spaces by retracting the front teeth back, we could make the profile look worse. The patient could end up with straight teeth, but uglier, less happy with their profile. If we look in the mouth and see that there's crowding, well, if we just straighten the crowding, that's going to push the teeth forward. So just straightening the crowding on this patient would make her look worse. And on this patient, we might want to try to limit the amount that the teeth go forward with maybe a little bit of IPR, which we'll talk about in a minute. Whereas this patient would look better if there was crowding and we got to advance those lips and fill them out a little bit. So this patient might need some teeth extracted to do the crowding case. This patient might just need some expansion and some tooth size reduction. And this patient would look better with the crowding. So the face type dictates how we decide to treat the case. Are we going to extract teeth? Are we not going to extract teeth? Are we going to try to move things forward or back? Are we going to do IPR or expand? Okay, every case is not just let's look at the teeth and decide how to straighten the teeth. It's let's look at the face and decide what's going to make them look better or at least look as good as they started. Okay, so understanding facial balance is huge. What happens is when we go and look at a ClinCheck, they don't have the software so advanced right now to where when we look at the software, the teeth in 3 dimensions, some of you may have never looked at a ClinCheck or never looked at a 3-dimensional setup, but we can look at that 3D model just like a scan. We can look at it in 3D, and then we can run the little proposal, which gives us all the steps. Like let's say there's 20 aligner steps. It'll show you each little incremental move that each new aligner is going to try to get the teeth to accomplish. And so we can run that little movie back and forth and watch how the teeth are proposed to move. But it'd be really cool to be able to see that in 3D with the face, where we could actually see like, well, how's that going to change this patient's face, right? But we don't have that. All we have is just the teeth and we ignore the bones and the face. And it's easy to focus on just those digital setups when we're looking at the proposal from the aligner company and forget that these actually are inside of somebody's head, that there are lips attached, that there's bones attached, that there are things that we need to understand besides just these teeth floating around in digital space. The other thing is if we don't take a lateral ceph, we miss information about how this patient's muscles work and how their teeth are more likely to move. Okay, so if you've never done any orthodontics, you don't really know the difference between these three different types of patients. But hopefully you can just see by looking that these are incredibly different patients. And most of the difference between these in their bone structure comes from muscle activity. Okay, so here we have what we call a brachyfacial or skeletally closed. So in the vertical dimension, everything is very closed. All of these lines that represent the different arches and angles of the face are very almost parallel. Okay, this patient is very compressed and the lower third of their face is not as long as the middle third of their face. This person has very strong muscles. This is the kind that breaks crowns that, if your filling is off just a little bit, it hurts. They have to come in and get it adjusted. These patients' teeth are very difficult to move. They tend to have deep bites in the front. When they bite together, you can't see their bottom teeth. Okay, their bone is incredibly dense and their teeth don't move easily. And if we need to move their teeth forward or back, it's actually easier to move their teeth back than it is to move them forward. So we would tend not to extract teeth on this patient because we can't close the extraction space because we can't get the back teeth to come forward. But this is the kind of patient where if you put a crown in, they'll come back in a couple months and they're catching, you close the contact with your crown and they come back and their crown has moved distally and now they've got all this food getting packed in between there. It's because the force of their bite has taken that new occlusal scheme and actually found a force to start driving the tooth back. Okay, these are really hard patients to work on for the orthodontics. This is what we call a mesofacial patient. They're just average. average muscle strength. The planes of occlusion, you know, when you look at their planes, they're moderately spaced. They're not as parallel. Okay, these are just normal muscle strength patients. These are more easy to work on. Teeth can go forward or back. And these patients are what we call dolichofacial or skeletal open or high angle patients. Okay, these patients, if we look at the angles of their jaws, they're very divergent. They're very open. So they're not parallel and compressed like this patient. Okay, this patient has a very long face. The lower third of the face is much longer than the middle third of the face. And on this patient, this is the patient you can put a high crown in, and they bite down and or they only hit your filling, but they don't even ever come in and complain about it because, you know, they tend to have dental open bite in the front. They just don't bite with very much force. Their teeth don't have any wear on them. They still have all their enamel lobes and all their cusps and everything. Okay. Their teeth actually move very easily. These are the patients you can extract teeth pretty easily on because their bone is just not that dense. And it's easy to extract teeth on them because it's easy to close the extraction space because their back teeth want to move forward easily. But in these patients, it's very difficult, if not impossible, to try to push teeth back because they just don't have the muscle strength to support that. And this is about a 3-hour conversation in the actual course, okay? But I'm just throwing it out there right now to understand that, like, there are reasons why we use full records to diagnose cases and understand what we're looking at, because the way that this case is going to treat, it can vary dramatically from one patient to another. This is an example of it's a screenshot of a setup from ClearCorrect. Okay, so if I were to be in their software and push this play button, you'd see this little thing move through these aligner stages. This one has 24 aligner stages. Okay, and you would see the teeth move. However, you can look at it in every different angle and we'd be able to see the teeth move the way that they're proposing to move them. But I wanted to show you this because when I look at this patient in the way that it's presented by ClearCorrect in their software, I see upper teeth that look very tipped back and lower teeth that look pretty tipped back. And I would feel pretty comfortable with letting those teeth tip forward as part of my treatment. Okay. But then I have to look at it and go, well, what's actually happening in the patient's mouth? You know, there's, if we look at these lower incisors, when we traced it, we saw that these lower incisors were actually very proclined. They were tipped forward quite a bit. This patient is a skeletal class 2, which means that the bone of the upper arch is more forward and the bone of the lower arch is more back. Okay, so we have like a class 2 bone relationship or skeletal relationship. So to compensate for that, the lower incisor is already at a kind of flared or tipped forward position. And so when I looked at it in the lateral ceph, my diagnosis was, I don't really want to fix the dental class 2, you know, the fact that these canines, this canine should be right here. So I was like, well, if I work class 2 elastics, throwing a lot of ideas out there, but if we wore elastics and move these lower teeth forward, on this model, it looks like that would be acceptable. But when you look at it in the mouth, I was reminded that, oh yeah, these lower incisors are already very flared. I wouldn't even have known that if I hadn't taken the lateral ceph. And certainly looking at it just in this digital world over here, I don't see that at all. To me, those teeth look kind of tipped back. Okay, and that's because of the shape of the crown. It's the fact that they put it on a horizontal, whereas in the mouth, it's at a different angle. There's a lot of reasons why visually it just looks different to me. But what matters is what's going on over here and how does the movement that they're proposing relate to what I actually diagnosed. Okay, so we tend to just focus in on just the digital setup and forget that there's bones attached. And, you know, the problem with flaring this tooth too far forward is it's very unstable when its crown is tipped way out away from its apex of its root. And it also causes recession and it tends to not look very aesthetic. So we do the diagnosis based on the full records that an orthodontist would have, and not just based on what we see from looking at the crowns of the teeth and from the digital setup. The other thing to consider with this patient is this patient has a straight to slightly concave profile. Based on the position of these lips, I would either want to let these lips move forward or at least keep them where they are, but I really wouldn't want to retract the lips on this patient because it would make the patient not look as good. The lips are in a good position. And I look in the mouth and what do I see? I see spaces. Okay, the patient wants to close those spaces. Well, the easiest way to close these spaces is just to leave the back teeth where they are and take the front teeth and push them back. Okay, because if we start to push all the front teeth back, so instead of, we start with the front teeth in this position, and we might end up at the end of it with the teeth further back in this position. Okay, and that's the easiest way for the technician to do it. It's the most predictable way for the aligners to do it. But the question is that the right thing to do on this particular patient? And if we just focus in on this digital setup and teeth in digital space, we tend to go towards what's the easiest, most predictable way to straighten those teeth and close the spaces, rather than what is the right way to treat this case so that the patient doesn't end up with straight teeth, but a face that looks uglier. And so in this case, we would want to actually close the spaces by protracting the back teeth forward so that the incisors can finish in the same anterior position where they started, so that the lips can stay where they started and not get retracted. So that's more work. That's a more difficult case. It's probably going to require some elastic use to help support, some auxiliaries to help support the aligners in a more difficult movement, which is moving all these back teeth forward. So every case is different. Whereas if this patient was one that had lips sticking out too far, and we wanted to reduce that protrusion, then we could go the easy route. We could just pull those teeth back and that would make the patient look better. And it was the easier way to fix the teeth. Okay, so we have to diagnose the whole face, take into consideration the bone relationship. Where's the limitations of where's the teeth going to hit the bone and find resistance to moving? And this is why some aligner cases, if you guys have done a little bit of aligners, some of them go fairly easy and some of them are really difficult because we don't really know. If we're just guessing and we just take impressions and photos and send them to the aligner company and they send us back a setup and we deliver them, sometimes it works out and sometimes it doesn't work out at all. And it's because we didn't really understand the case going into it. Okay, so our goals of treatment is facial balance first, keep the patient looking beautiful or make them look more beautiful. Obviously straighten the teeth. Fix the bite if we can. We'd like to finish in a class 1 occlusion, but that's not always possible. So we at least need to get them good function, even if we're not able to give them a full bite correction. To consider the periodontal health, we don't want to tip the teeth to where we're going to cause recession. Make sure that we can get a functional position that's going to be healthy for their joint long-term, and give them a result that's going to be successful in the long term, rather than something that's going to be prone to just rapid relapse if they don't wear their retainer. Okay, so we're not going to this is one of the things that I really love doing in our courses is actually going through, we'll spend hours going through, cases, and we look at one patient and we diagnose everything. We talk about everything that could be going on in that patient. And then we watch the treatment happen and we talk about what went well and what didn't go well and what would you do differently and what do you like about the way it went. So we're just gonna take a couple minutes based on our time today to just look at 2 cases real quick, but just to give you an idea of like what we're doing when we do these cases together. So this patient to me, looking at her profile, she looks like one of those mesofacial patients, the average muscle strength, okay, average vertical dimension. If I look at the line from the tip of her nose to the tip of her chin, I would say she has a straight profile. Okay, her lips she has a nice facial balance. I don't feel like we need to make the lips go forward to look better. And I don't feel like we need to pull the lips back to make her look better. So I'd like to finish with her teeth kind of about where they started, whatever position that is. Okay, when she smiles, her midlines look good. The only thing that really jumps out at me in the smile is it looks like I'm missing a tooth right here. It looks like there's a gap in her smile right there. So I'm like, well, what's going on there, right? Let's look at it and figure out. And I also am a little bit leery when somebody actually has a pretty nice looking smile to start. I'm like, well, I wonder what she wants. Is she going to have realistic expectations? Is what she wants something that I can give her? Or does she have crazy expectations? So let's look in her mouth. And even though she looked pretty good from the front, when you look in her mouth, you can see why she wants aligners or braces. Okay. the fact that it looks like there's a tooth missing is actually because those bicuspids, especially the one on her upper left side, pretty sure it was her upper left, yeah, on her upper left side, was pretty compressed. Okay, and then she also has a bridge. We can't move those with the aligner. Those are going to have to stay put. So that's going to limit to some degree how we can move these teeth. But she definitely needs some alignment in the lower arch, and in the upper arch, some anterior alignment. But this is one of those cases where we would really like to develop the arch form. The arch form is kind of compressed through the bicuspids. It'd be really nice with the aligners to move these teeth out into a nice arch form and help the dental alveolar process, that bone that holds the teeth, to remodel so that the teeth end up in a nice stable position. Aligners can do a good job of that because aligners cover the lingual surfaces of the teeth in addition to the buccal and the occlusal surface. And so the aligners can apply a force from the lingual side pushing towards the buccal side. Okay, so let's see how that came out for her. It probably took her about 16 to 18 months worth of treatment. It looks like her profile stayed about the same. Her lips didn't go out or come back. She looks as nice as when she started. Her smile looks more full. Okay, I can see those teeth. They're not hiding behind the canines quite as much, and just generally they're nice and straight. Okay, so these teeth have popped out a little bit better. So let's look what that looks like from the occlusal view. Okay, so you can see how the aligners were able to develop that arch form. Not as much as you would have wanted on this side. It still feels like it could have gone a little bit further, but remember, we had a limitation. There's this lower bridge. See the bridge right here? She has a bridge down there. That bridge isn't going to move. So we're limited on how far we can move these teeth out because we cannot move those lower teeth with it. Okay, so sometimes we run into some limitations. But overall, really nice development of the arch form. Teeth got straight in both arches, and a really big improvement to her smile. It filled out those areas where her bicuspids didn't look like they showed up in the smile. And her profile stayed beautiful the way it started. Okay, so that was a well-treated aligner case, and one that the kind of case you should look for to start aligner cases in your practice. Let's look at another case real quick. Okay, this is the one I was talking to you about, patients with open bites. Okay, oftentimes they have a tongue thrust. That's the reason why they have the open bite. It may not have been what caused it, but they've developed a tongue thrust and maintained that. Okay, so especially with younger patients, myofunctional therapists, I had a myofunctional therapist that I had a great relationship with, and I referred a lot of orthodontic cases to them to work with me on the case. Because sometimes patients need to retrain the muscles in their tongue or their lips to function properly so that the teeth will go in the right place and stay in the right place. Because, if teeth will move when I put a force on them, an orthodontic force, they also move in relationship to the forces that they put on their own teeth from the muscles. Okay, teeth are where they are based on the shape of the bone and the muscles that surround them. They find equilibrium, so the way that the patient's tongue functions and the way that their lips function and all the muscles around their, face function, the teeth have found an equilibrium inside of that envelope of space where the muscles function. So changing the muscle function can also help us with changing the teeth, especially with open bites. If I see a younger patient who can't breathe through their nose, I refer them right away to an ENT. I don't tell the ENT what I need done. I just tell the ENT that I need them to give me a nasal passageway, because my patient, if they can't breathe easily through their nose, if the airway is constricted in the nose, it's going to be very difficult for me to get them to seal their lips and breathe through their nose because it's clogged up. They don't have a passageway for air to go through. So I need that so that as I start to close their open bite and get them to learn how to keep their lips together, they don't die, they can breathe. Okay, so using referrals to myofunctional therapists, ENTs sometimes can be a big part of treating these open bite cases. Okay, but aligners are better than braces when it comes to closing dental open bites. Some cases are so severe that the only way we can treat it is surgery. But many of you may have seen that even in a surgery case where an open bite has been treated surgically, they'll relapse. They'll completely close. They'll, move the mandible into a fully closed position. And then years later, they've relapsed into open bite again. And that's because they still have the same myofunction. Their muscles still function the same. And so they recreate the same pattern they had before the surgery over time. So in my experience, as long as it's not a crazy huge open bite that needs surgery, no matter what, if it's something realistic, if I'm able to close it with aligners and maybe a myofunctional therapist to do some retraining, those cases last much longer and have much better long-term success than one that's been closed with braces or surgery, because they function differently. And the aligners somehow make them function differently. They use their mouth differently when the aligners are in. Okay, so let's look at this case. Here's this young 20-year-old patient. His teeth are actually straight. He's had braces before, and he's biting together all the way in the back here. But you can see that his teeth don't come together in the front. So when he eats pizza or sandwiches, he leaves, the meat and the cheese behind. So here you go. When he bites together, his front teeth are completely open, and he's showing you his tongue thrust. So see, I like to put my tongue into this space right here. Teeth are perfectly straight. That's not the issue. The issue is, what are we going to do to get these teeth to come together? And if we were to just extrude his teeth, like pull them down in the front to the point where they finally touch, he might have too much like gingival display. It might not look very good. So it would be better on him to actually close his bite by intruding all of the back teeth away from each other. Okay. And aligners can do that, especially if we can encourage the patient to squeeze and clench, and we put certain things, which I'll show you in a minute, into the aligner setup that encourages the back teeth to intrude. Sometimes we might decide to go ahead and extract the eights, the wisdom teeth, because those teeth are way back there in the wedge. And just like a little nutcracker, like if I have a nutcracker, here's my nut. The further back I move the nut towards the hinge point, the more the beaks in the front will open away from each other. So if I have teeth really far back towards the hinge point of the jaw, those will kind of like hit first and keep everything else from coming together. So sometimes picking up a burr and doing an occlusal adjustment on those cusps on the third molars, or even just extracting them, will help us to close the bite a little bit to start. Then we set up our aligners so that we're intruding the back teeth. And as these back teeth move away from each other, the patient is able to rotate the jaw further forward and get the bite closed. And then I give them some exercises to do with the tongue, retrain the swallowing. Okay, but right now the patient has to swallow with their tongue sticking out there, because if they don't, then the food and the water squirts out the front. So it's a process to retrain, but it works really good with aligners. So here's the patient after about 18 months of treatment with aligners. You can see that the patient almost looks like they're able to, like he's able to close his jaw up a little bit further. And for sure, the bite comes together in the front. The teeth were always straight, okay? They're still straight. But now the back teeth have been intruded away from each other. The patient is able to bite on the back teeth and get the front teeth together because the jaw comes further closed. This is what the setup looks like. Oh, here's the before and after. So you can see that the back teeth were intruded away from each other, and that allowed the front teeth to come closer to each other. There was a little bit of extrusion of the front teeth as well, but not so much that would make the patient look unattractive. Okay, so a little bit of extrusion of the front teeth. By the way, extrusion is a very difficult thing for aligners to do, to actually pull teeth down. Okay, braces can do that really well, but aligners don't do it as well. They intrude back teeth easier, and they don't do a great job of extruding. And so you would think, well, don't braces then do a better job of closing an open bite, because with the braces, I can extrude the front teeth? And you would think so, but it's not very stable. And it oftentimes looks very unaesthetic, because the patient with the dental open bite already showed too much gummy smile and too much of their teeth, and pulling them down to close the bite makes them look even worse. So there's just a screenshot of a case, not the exact same case, but a case where we have dental open bite. So here's what the teeth look like to start. And the way that we set the case up, this is what it looks like from the side to start. is we want the technician to finish the case where we have the back teeth moved away from each other to the point where there's basically, it looks like there's open bite in the back. And then we're going to put these little engagers, these little composite, handles on the teeth to help us extrude the teeth that need to come down a little bit. So we're doing a little bit of extrusion of the front teeth. And we're also locking the aligner in place on the front teeth to help us push up on the teeth in the back. Okay, so it's a specific type of setup that allows us to close open bites. And we also go and put little engagers or little bumps in the aligners on the biting surface of the back teeth so that when the patient bites and clenches, the extra thickness of the aligner on these little bumps helps to drive the teeth away from each other in the back. We talk a lot more about this in our classes when we talk about open bite, but there's tricks, there's ways to set up these cases so that we are getting dental open bites to close with the aligners. And once they close and they continue to wear these clear aligners as retainers, they do really well with these over time. Love to talk more about these cases, and we will when we have our classes together, but we're trying to limit this to just a little bit over an hour, so I got to keep moving here. Okay, so with our setups, with our ClinChecks and the way we set up a 3D case, we try to set them up in ways that compensate for difficult or less predictable movements. So just quickly on that, rotations can be hard to fix with aligners because the aligners don't grab the tooth well enough to really rotate it. So one of the tricks is to make sure that tipping teeth is really easy with aligners. It's very easy to tip the teeth to the buccal. So if we tip them a little bit to the buccal, it actually opens up little interproximal spaces. And once there's some spaces there, that's when we start correcting rotations so that there's no binding of the teeth because it's already a difficult movement anyway. Okay, sometimes if we have a lot of root movement to do or a lot of rotation to do, we slow down the rate of the movement so that the changes are smaller, more incremental changes. It's going to take more aligners, but it's more likely to happen because we've slowed down these difficult movements. Because if the aligner wants to change, fix a rotation really fast or move a root really fast, the patient will wear the aligners and they just won't track. The teeth won't do what the aligner wants it to do because it's just trying to do it too fast. And then there's some movements that we over-engineer. Okay, we basically add more to the setup than what we wanted. So, if I have a rotation of like an upper lateral, those are sometimes hard ones to rotate. Instead of just rotating it straight in the setup, we'll rotate it like 4 or 5 degrees beyond straight so that we have a chance of actually getting them straight. So we've over-engineered the setup. Or if we're trying to intrude the front teeth to get rid of a deep bite, or we're trying to torque the front teeth, meaning we're going to like twist the roots to go to the lingual or to the buccal, we're going to add more to the setup than what we actually want. We're over-engineering because we know that the plastic is flexible and it has, some weakness. And so we don't expect to get 100% in the mouth the way we see it in the digital setup. So we're going to over-engineer certain movements. And we talk a lot about that. We apply certain engagers or attachments to the teeth to help get the teeth to move. And sometimes we use auxiliaries like buttons and elastics and things to help add a force to the tooth where it might be a difficult movement for the aligner to do by itself. Sometimes, like I said, we consider starting with braces or finishing a case with braces. Okay, one other tip is if we have upper molars and we're trying to do a little bit of expansion. So here's the one on the right, here's the one on the left side, and we're going to expand out buccally. The crowns are going to tend to want to tip. So sometimes we'll have the technician add extra buccal root torque, meaning they're going to tip the root further to the buccal than they're tipping the crown. Because we know that the crowns are going to tend to tip in the aligners, and so we over-engineer it and try to get the root to stay parallel with the crown as it expands out. So there's all kinds of little tips and tricks that you learn along the way in our courses to help you do these setups in a way that they're going to be more predictable and you're going to get better results from them. And if you just send them to technicians, like, well, why don't they just, why doesn't Invisalign train their technicians to just do all of these things? And the bottom line is they just don't. There are some technicians that have been there longer, have more experience, but usually they're dedicated to the clinicians that are like the high level ones that do tons of aligners with them. And so they have a dedicated, really experienced technician. And when we come on as newbies, they just give you one of the newbie technicians and you get what you get. So we have to understand how to make things move properly so that we can get a good setup and good aligners that are going to work. Okay, we're going to help you understand how to identify and resolve tracking issues. For example, here you can see that the upper central incisors fit very nicely into the aligner. There's not a big space between the edge of the plastic and the tooth. But if you look at this canine right here, you can see that the canine should be down lower and it doesn't seem to be tracking. It doesn't seem to be wanting to come down. Okay, there's an engager in place to help pull it down, but it's just not working. So recognizing that there might be some binding, some tightness in the contacts between these teeth that's keeping it from coming down, so that we're checking and we're going in with little diamond strips and we're relieving the tightness between these teeth so that the tooth can come down without binding. And then doing things like using a chewy and having the patient bite repeatedly day after day on this aligner, which will flex the plastic up. And then when they release, it'll grab the tooth and pull it down. And you do it over and over and over, and we might be able to get the tooth back on track that way. Here you can see that these lateral incisors are not tracking well with the aligner. Okay, they're not coming down the way the aligner wants them to, and there's this gap. Okay, so what do we do about that? We talk a lot about these types of tracking problems and how to resolve them. So without spending a lot of time, because we don't have the time, but I'm just going to throw this picture at you so you get an idea of what I'm talking about with auxiliaries. Okay, a lateral incisor that's not coming down with the aligner, we can go up and we can adjust one of the aligners, bond a little button on the facial of the tooth. And on the lingual, we have to do the same thing. We have to adjust the aligner and bond a little button on the lingual. And then the patient puts their aligner in and wears a little elastic over the aligner. So it goes from the button on the facial to the button on the lingual. It goes over top the aligner. So they have to take it in and out every time they put their aligner in and out. But as long as it's not binding interproximally, this elastic will really handily pull that tooth down into the aligner. So something the aligner was struggling to do on its own, you throw a little auxiliary in there and it works out really well. Sometimes we have a hard time settling the occlusion in the back and we have to throw buttons in the back and put elastics in the back to get the bite to settle. Okay, we spend a couple hours talking about this one because it happens a lot in aligners. Sometimes we wanted all the front teeth to come down and we end up, putting buttons on all the front teeth and pulling them down into the aligner. And if I haven't had this conversation with the patient and set that expectation ahead of time, they're going to be disappointed when I have to put buttons and elastics on their teeth. But if I realize what movements might be challenging and we've talked about that up front with the patient, then if the time comes that we need to use them, they're like, oh yeah, we talked about that. Sure, let's go ahead and put them on and get it done, rather than looking like it's an excuse. Okay, we're going to spend a lot of time in our courses talking about interproximal reduction, IPR. Okay, when is it appropriate to make teeth a little bit smaller? Unfortunately, too much IPR is prescribed by technicians. I should say technicians. Okay, the easiest way for them to straighten the crowding is just to make all the teeth smaller, but that's not the appropriate way to do it. When we do braces, we don't just make all the teeth smaller. The teeth move, they get bigger in the arch form gets bigger so that all the teeth can fit. Sometimes it helps us in a certain case to do a little bit of tooth reduction, but we don't do it on every single case. But if we just send these off to aligner companies, they do it on almost every single case. So too much IPR is being prescribed, and often it's being prescribed at the wrong time when the surfaces of the teeth, the true contacts, are not even really aligned. So the technician wants you to go in there with a rotary disc or a strip and start, grinding between the teeth. And it turns out you're actually grinding away the wrong part of the tooth. And once the teeth get straight, you've actually removed part of the tooth that makes it so it can't even look right. The tooth has been damaged. We only really want to remove tooth structure from the true contact point where it's going to be in contact once it's straight. So there's a lot to talk about when it comes to, when is it appropriate to apply interproximal reduction? When do we use it to treat cases? How do we do it? How do we evaluate it in our setups? because this is one of the areas where a lot of doctors get themselves into trouble because the technicians apply way too much IPR at the wrong times. The doctors are like, well, I'm supposed to do it, and they go in there and damage teeth. Okay, so just wrapping things up here, our philosophy is to help you select cases that you can treat in your office and be successful at your level of experience. But we also want to help you build confidence, so as you take on cases that are appropriate for you, you're going to enjoy it. It's not going to be a frustration where you're like, you know what, I hated this. It was frustrating and stressful. And at the end of the day, I didn't even make any money. I lost money on that case. We don't want you to do that. We want you to take cases where you're like, it was fun for me. It was fun for my staff. It was fun for my patient. It was rewarding. It went well. And I made money, for what I got paid and the amount of time I put into it, I made money on that. And as you continue those types of cases and it gradually increase in the complexity of the cases that you've done, you end up treating hundreds of cases and having a really rewarding and profitable part of your practice. We really want to see you succeed. So in POS, one thing I love about them is anytime you take a course from them, you can always go retake the course. If you take the course, via webinars, you can always go to a live course if it's presented in your area or you want to travel somewhere where it's being presented. Some people sign up for like a self-study course and then find that they just aren't getting through the material. And then they can just go show up at a live course, register for the live course and go and say, I'm taking this weekend, I'm going to go actually like really invest some time and learn this stuff. Lifetime retakes, you can always go and retake in any of the formats in which it's offered. You can go and retake any course that you've ever paid for. But then we are here as instructors and consultants, mentors to help you with your individual cases. Help you select your case, help you diagnose and treatment plan your case, help you to evaluate your setups. And then, that's consulting. That's kind of helping you plan your case. Or you can do the mentoring level where we follow the case with you. We go through the case and you give us progress reports and you send us photos and questions as you have them. And we help you throughout the whole entire, we get onto the job site basically, and we help you with questions or concerns along the way. And you'll learn more about those services in our seminars as we talk about them. Okay, so mentors or consultants will review your records. You have to take the records and tell us what your patient's treatment goals are, but we look at that with you. We will trace your lateral ceph and help to diagnose, or we will diagnose the skeletal patterns so we can understand how the teeth are going to move. Okay, we trace your study models and create what we call a visual treatment objective so we know how we want to treat the case, make a treatment decision. And then we will decide, can this be done with just aligners? Does this need some braces in addition to the aligners? Or are we going to need some auxiliaries? And so we write a plan and design an appliance for you. And we'll give you specific directions to give to the technician. Like, hey, if you're going to submit this to Invisalign, here's how you're going to submit it. If you're submitting to ClearCorrect, here's how you're going to submit it. And then you'll give us access to those setups and we'll review them with you and go, oh, this technician followed our instructions really well. It looks great. We just need to make one little minor change, then it's good to go. Or we might say this technician did a horrible job and this is nothing like what we want it to look like. And we have to go and try to get a setup that looks the way we want it to look. But we're going to stick with you until that's accomplished. And then once you approve your setups and you get your aligners ordered, if you were doing consulting, that's where that service ends. And if you're doing mentoring, we stick with you until the case is done, whatever's needed until it's done. And doctors can always upgrade. If they've paid for consulting, they can always upgrade and do mentoring if they have problems partway through a case. So I just want to recommend to you Progressive Orthodontic Seminars. I'm an independent contractor. I'm an instructor, but as a company, they are very ethical, high level of teaching. You're not going to find this level of orthodontic teaching for GPs anywhere else. High level of support. And what's cool is you get to earn while you learn. So you can start cases right away and actually have income coming into your practice to help pay for your education. The lifetime free retake policy I was talking about, awesome software. You can go on smilestream.com and look at the software and get a free account there. And they have traditional braces courses and aligner courses taught in 4 different formats. I love the in-person format where you come and sit with other people in class and learn in person. Okay, but there's other ways to do it as well. There's virtual classrooms where we combine, shorter Zoom courses with self-study that you do at home. We have fully self-paced, where everything is done at your own pace with self-study at home. We have internet-assisted training, hybrid courses. Okay, so the POS support team that's here, if you're interested in your ortho education, can help you look at these different formats and choose one that fits your style of learning and the time that you have available. Okay, the Aligner Plus courses are in person, are 4 different 3-day seminars. So we get together on 4 different weekends for 3 days each time and just learn a ton. Okay, the internet assisted training hybrid course is a 1 3-day in-person seminar plus self-study. We have a webinar series that's starting in September that I'll be teaching. It's 10 2-hour webinars plus you do self-study at home. So we never get together in person, but if you decide later you want to go to an in-person course, you always can. And then there's self-paced videos and instructions that you can do at your own pace. This is the schedule for this year. We have classes starting. Okay, so today is this intro webinar that we just did. Starting September 13 will be a Zoom course that I'm teaching. That's 2 hours every Tuesday, depending on where you are, the time zone and all that stuff. But we get together every week for 10 weeks. And then there's stuff that you do at home as well. We have live classes starting both in Chicago in September. So there'll be 4 weekends, starting in September, and another one starting in October in Orange County. So I'm going to leave this schedule up here. It also mentions some of our traditional braces courses that are going on, and I will take questions from those of you who had questions along the way. And thank you, those of you who need to go. I went over just a few minutes. I appreciate you being with us and taking time. It was awesome to be together. So any questions that you have for the support staff or for me, you are welcome to either type those into the chat or simply unmute yourself and ask the question. There's not so many of us on here that you couldn't just go ahead and unmute yourself and just ask the question. I'm looking at the chat here to see if there was any questions typed in while we were talking. I don't see any, but does anybody want to ask a question? Anybody want to unmute themselves and ask a question? I have a few minutes, or you can type them into the chat. Hopefully I wasn't talking so fast that you weren't getting some of that. Hopefully I gave you some interesting things to think about.
It was very good.
Must not have been too good. Nobody has any questions, or it was so good that nobody has.
Or it was so good that, yeah, you answered.
There's no reason to come to the courses now because everything was taught. It's really good. Well, as you can tell, I really love talking about ortho and really love working with doctors. I just got a note from a doctor the other day who's like, I cannot believe how much I've been learning. I'm so grateful for the way that you're helping me learn. And it's so fun. And I'm having it's like a whole new career, It's getting bored with with general dentistry. I've been doing it for 20 years and just it has completely brought new life to the practice, and super excited about his patients and his cases. And it's super fun for me. So thank you, Chandra. Prices for the Aligner courses. Iveta, do you want to talk about prices? It was on one of the slides, but I skipped over it kind of fast. So maybe while we still have everybody on here, you can go over the pricing for the courses.
Yes. So if somebody is already a POS member, there is a discounted rate, but the fee for the Aligner class, if you prepaid in full, is $5,600. And basically it's 12 days of education, and it includes the kit that is valued at $1,200. And either format you take it, as Dr. Harrell said, you can take the webinars and then you can retake them live, or vice versa. You would have access to all the 12 days of seminars.
And some doctors will break that down into, if you're paying it, like if they go to the live seminars and they're paying it like for seminar 1 and then seminar 2, and they just pay it as they go, what is that?
The fee is a little bit higher, but yes, they can always start with just seminar 1. Like one seminar is $1,400, that seminar 1 is discounted to $1,200 the first 3 days. And then they can still decide if they want to just pay as they go, $1,400 each, plus the kit, or they can prepay the difference and they would still be paying the $5,600. So they can start with the $1,200.
Yeah. And you learn a lot, if you're new to ortho, you learn an awful lot in seminar 1, just about orthodontic principles. You'll look at your patients differently. So there's a lot covered in those first 3 days. I'd really encourage you to, some people do well with self-study, the self-paced stuff, but it's a lot more interactive to be together in person, or to at least be together 2 hours a week in the webinars. It's just fun. We learn from each other. It's a lot more interactive when we do the webinars than what we did tonight, because we have time to let people ask questions, to get to know each other. We're together for 10 weeks. I really love the live courses because I just like seeing your faces and, not looking at blank boxes on a computer screen. So for me, from a teaching standpoint, it's fun. I always learned better when I was actually at the weekend courses, because I set everything else aside and just dedicated those days to learning. When I have to self-pace through part of it, if it was the webinars, I would probably show up for the webinars, but I have kids and I have stuff going on, and sometimes it's hard to self-pace. Some people do really well with that though, and they want to, they have time, they want to study at home, and coming to the webinars helps them to kind of stay on track and keep excited, and we get to ask questions and stuff like that. So everybody has a different format that works well for them. I'm the kind of person where I just like being together with other people and learning in person. And I know COVID's kind of changed that, and people are more used to Zoom and stuff like that now, but yeah, it's
But I wanted to mention, Dr. Harrell, that also if we have the live seminars, they are also offered by Zoom. So sometimes
right. You guys are broadcasting live.
We are doing both. Yes.
And me personally, if I was doing the self-studied one, I would probably go back and watch the previously recorded live weekend sessions. I would probably just go, this weekend, I'm going to watch this, and I'm going to get through as much of it as I can, because I just like watching or being a part of the live seminars. I think they're awesome. So yeah, that's a good point. Those are being offered virtually, even though they're being presented live. So,
and yes, this webinar is being recorded. So anybody who wants to watch the recording, you can send them the link.
Thank you. If you're interested, if you enjoyed talking about ortho, if this kind of piqued your interest, and you're like, you know what, this is cool, I like that, I want to learn more about this, I know that the POS staff will be reaching out to you, but you can reach out to them and just talk about your schedule, what works best for you, what dates and areas are available that might serve you well, or join our webinars that we're going to be doing, and just see what's going to work best for you. Maybe you pay a little bit and try it out, or maybe you're like, I'm all in, I'm going to pay the whole thing and get a discount and just commit, and I'm doing this. But I know that they will help you figure out what's going to work best for you if you found that you really like this. I can guarantee you that you will love the education, and that you'll love being able to do this stuff in your practice with your patients. It's definitely the best thing I ever did in my practice. Any other questions before we end it, guys?
Yeah, Doctor, I have a quick question.
Yeah.
Sorry, my son might be crying.
That's
You can just
okay.
ignore that.
We've all got families and pets and all that stuff. So what's your question?
So you mentioned during the clear aligners where if some teeth are really not moving, they're very, tough to move or not budging or extruding. You're placing these buttons on mainly the lingual surfaces.
So let me
if
go
they
back.
don't fit, how that seemed like very complicated.
Let me go back and show you that picture really quick.
Especially the canine, or how you filled in the other teeth. Yeah, this one on the bottom right. I mean, with that button's going all the way at the cervical margin, and then you had one at the lingual with the canine.
So basically what you have to do, the aligner you just stay in one aligner. You're like, okay, this is the aligner I'm going to get caught up in. You have to use some interproximal diamond strips to make sure that the contacts between the teeth are light, because if it's binding, there's no room to bring the teeth down. So you have to make sure that the interproximal contacts are light. And then you're going to bond. There's all kinds of different buttons out there, but you're going to bond buttons on the cervical of the facial and the lingual. It has to be on both sides of the tooth that you want to bring down. Okay.
Are you putting elastic on the lingual?
Yes. So once you have the buttons bonded on the lingual and the facial, then you need to adjust that that aligner. The aligner has to be cut so that it fits with the buttons in place.
Okay,
And
you cut the aligner, yeah.
yeah, because look at, if I have the aligner, normally the aligner would be where the buttons are, so that wouldn't work. So you have to get out scissors and actually cut your aligner. That's why you're only going to do it in one aligner rather than do it like in every successive aligner. So you're going to cut the aligner. You're also going to make sure that you've cut it, because if I cut the aligner so it fits with these buttons in, but it basically, if the tooth were to move down, the button would hit the aligner. That's not going to work. So you have to allow enough room so that the button can exist on the tooth together with the aligner, and there's enough space for the button to be able to move incisally.
And
Then,
you have space in between the incisal edge and the edge of the aligner?
Yeah, so then when you put the aligner in and you wrap this, this is a 4.5 ounce, 3/16 inch elastic. They give them animal names in the orthodontic world. This is typically the gorilla.
Okay.
And so the patient is going to hook the elastic onto the button on the facial, and it's going to go over top the aligner and hook onto the button on the lingual. And then what happens is the elastic is pulling the tooth from the facial and the lingual down towards the incisal, and it's going to keep pulling until it hits the edge of the aligner, and then it's going to stop. So you have your patient continue to wear these elastics. Every time they put the aligner in, they put the elastic in so that they can pull the tooth down until it's in the bottom of the aligner and it's back on track. And once you're back on track, then you can remove the buttons, you can put your engager back on the tooth, and you can continue with treatment. But this is a way to get that tooth down, you know, whether it's just one tooth that's not tracking or whether it's a whole series of teeth. This is how, one of the ways that we get the tooth pulled down into the aligner. Was that helpful?
It was very helpful, but in the posterior, you have the metal buttons.
Yeah, mainly
the
because
same thing.
You can use the clear ones too, but the metal ones, they're cheaper and they're a little bit easier to get on the teeth. And since it's not aesthetic, it's not as big of a deal. On this one, they're not on the lingual, okay? So what's happening here is the aligner is trimmed on the facial, and there's buttons on the upper and lower teeth, and the elastics are being worn from the upper buttons to the lower buttons. Here, they're not being worn from one arch to the other arch. They're just like, the lingual and the facial are pulling towards the aligner. But here, the top and the bottom teeth are pulling towards each other. And if you didn't have the aligner in place, having these elastics just pulling on the facial, if you can imagine, start pulling these buttons closer to each other, all it's going to do is tip those teeth to the lingual.
That's what I was wondering. Isn't that going to tip everything? So the liner is holding.
But think about it.
Lingually?
On the lingual side, you have the entire surface covered of the tooth covered with the aligner. You've only cut away the aligner where you've placed the buttons and enough room for the buttons to move. So even though it wants to tip the teeth to the lingual, the aligner is like a catcher's glove. It's literally guiding the tooth in the position that you want it. And the elastic is just providing more force to the tooth to drag it down. But if you did that without the aligner, that would be horrible. It'd be completely uncontrolled. Those teeth would completely tip to the lingual. But because
is it faster?
Yeah. It
to do it on the lingual and the buccal?
No, not on the back teeth. So on the back teeth, you just want to pull the top to the bottom. If you only had one tooth, like let's say you had one tooth in the back that needed to come down, yeah, you would go buccal to lingual. But usually when we have the problem in the back, we're trying to get upper and lower teeth to all extrude towards each other. Whereas when we're in the front, we're dealing with like this one tooth that should come down to look aesthetic, and it just didn't come down. But in the back, we're dealing with trying to get the bite to settle, trying to get the occlusion together. Does that make sense?
Yeah, thank you, doctor. That's
You're
a
welcome.
lot more.
I wish that I had more time. You know, I kind of threw a lot of ideas out there fast, and I wish I had the time to really go into all the details of all this stuff, because it's really cool stuff. It really is fun to talk about and figure out. But thank you for asking that question. All right. Any other questions before we call it a night or morning, those of you that are in India? Well, thank you so much for joining us. I really enjoyed being with you tonight, and feel free to reach out to our Progressive Orthodontics seminar staff. I know that they'll be following up with you as well. And hopefully we meet soon at one of our webinars or one of our live seminars. I look forward to getting to know you, helping you in your practice. All right, see you later, everybody.
Thank you. Bye, everyone. Thank you.
Thank you.
Bye.